today. We have a great lineup of speakers. We will be talking about COVID-19 diagnostics and the challenges of testing for COVID-19. And that will be presented by Dr. Diulu Kabongo. And then we'll also be having a country report on Ghana's pandemic response from Dr. Joe Bonney. So a great lineup of speakers. We're really excited to have them both. And so that I don't take up any more time, I'm going to hand it over to Dr. Kabongo and begin presenting his presentation.
All right, so I picked on this topic because I think it's some kind of important topic, and so far we haven't been covering it with these webinars. Next slide. And it is essentially for me to try and bring to the fore some statistics that exist already on the testing, but particularly look at the different types of tests that we use, as well as their validity, and lastly, then draw some conclusions on some clinical implications. So we'll use the three kind of titles to navigate through. I just want to remind you that I am not a specialist in virology, so some stuff might be well over my head, but also whatever we say today of COVID will probably not be true in 2, 3, 4 months time. So we probably need to know that. But also, I want everybody to be clear that I do not want to discuss all the biologicals, meaning hematology, chemistry, derangement during COVID. It's essentially the tests for the diagnosis of COVID that I want to discuss. Next slide. So as we do the tests, whatever numbers that we get, they just essentially give us two things. Number one, the number of tests we run, or the number of patients or people that we have tested. And number two, those that will then be confirmed as having COVID. That's all we have. We do not get, through those tests, we do not get much information about in the community how many people have really been infected with COVID. So the test then becomes just one window that is open into the reality of COVID, but does not give us a holistic view of the situation on the ground. Next slide. If one needs to have a clear view on the ground of particularly how many people have been infected in a certain population since the COVID started, what you need to do is to reach a ratio of 30 tests done for only one that is confirmed. I'll give you an example. So if a country says they have 100 confirmed cases in the last 24 hours, for that to reflect the reality on the ground, they needed to have run 3,000 tests. That's what it means. Next slide. So the difficulties we have, actually, one can see them even through the policies that different countries are using for the testing of COVID. On the map that I've given you, the countries that are in dark blue are actually countries that do extensive testing, that they have booths for driving, for instance. Anybody who wants will just go there and test themselves. But that's just a few countries. And South Africa, in Africa, was one of those countries that were doing that, but that changed at the beginning of June. And now South Africa would only test those that are about 55 healthcare workers and the symptomatic patients. The great number of sub-Saharan countries would do patients that would do people who have got symptoms and are in particular groups, like health workers or having comorbidities and stuff. There are also countries in Africa where there's no policies at all, like Tanzania or Algeria, there's no policy at all. Next slide. Of great interest is actually that once you get one person is tested positive, and what effort then do you do to try and trace in the community where the patients may be? And even in that, you still see a lot of differences. Again, your dark blue represents those who do like comprehensive. Any single person who was in contact, no matter what was the contact, they would test them. And a great number of sub-Saharan Africa would just do limited tracing. So all of that shows how much in Africa, we're not actually looking for patients and trying to really know in the community how many people have been exposed to COVID. Next slide. So coming to the ratio of 30 to 1, 30 tests for 1 confirmed, when you look at it in the world, this does not represent all the countries, but at least you can see that no single country, no single African country is above the red line to show you those that are actually achieving the numbers that can kind of give them an idea of how many are infected in the community. There's just South Africa somewhere that would make about 10 tests for 1 confirmed. Unfortunately, even countries that are well off, like Canada, like United States, can't reach that ratio. Next slide. So this one is a far-fetched kind of comparison I'm trying to do, but at least it also drives the message to where I'm trying to take it, that we have serious logistical issues. So we know that for one, to be sure that you can arrest transmission in the community, you need to have the so-called herd immunity. And in COVID, the number changes from one disease to another one. But for COVID, it is said that you need that herd immunity to reach about 70% for you to be able to stop the transmission in the community. But when you look at this, just looking at 1,000 patients, so if we have to stop, it means 700 patients. 700 people need to have antibodies to COVID. Now, I know that most countries don't run the antibody-based test. So I just looked at whatever test we run and see if the numbers that we run can reach the 700 per 1,000 population. And you can see it is only Denmark that goes to 180. Everybody else is way below those numbers. And South Africa sits somewhere around, I think 25 or somewhere there. So we're very far from actually knowing the truth of how many people have been infected. Next slide. So what test do we use? Next slide. Before I mention the tests, there's that nice picture from the Center for Evidence-Based Medicine, which is actually showing us the different parts of the virus. And the test essentially is done to detect fragments of the virus, whichever, either it is the spikes or some fragment of the envelope or some fragment of the RNA or antibodies to any of these fragments. And that's what the tests do. Next slide. So whatever the tests do, if you have to find fragment of the virus in the different specimen we take, either in the nasal swabs, the pharyngeal swabs, the bronchial lavage, you can actually get those few days before even the person develops symptoms. For you to get antibodies, you really need to wait after symptoms have been developed, and we'll come up with a discussion about that. Though in the pictures, it shows that about after 1 week, you can start showing them, but there's a longer discussion about that. So that's essentially what it does. And all of these eventually will drop, and then you won't be able to detect them anymore. What is also important to know is the PCR test, the RT-PCR test we do, actually looks for viral fragments, not viable viruses. So that's very important to know, because a lot of time the fragment of the virus can stay in the nasal secretions for a longer period. That does not mean that the person is still having the disease. So that's important. If you do the culture on these, studies have actually demonstrated that beyond 8 weeks after the symptoms, you start not being able to culture the viral fragment that you get into from the nasal swabs, for instance. When it comes to your antibodies, there are different types of antibodies that the individual produces. Some are directed to the nucleocapsid of the virus, and most of the antibodies that will be found in an individual that is infected of COVID would be antibodies to the nucleocapsid. And unfortunately, those are not neutralizing antibodies, so they cannot protect you. The neutralizing antibodies are those that are directed to the receptor binding domain of the virus. So the part that will bind onto the AC2 receptors. And those antibodies are actually neutralizing antibodies. And unfortunately, they are not, in an individual who's infected, they are not the biggest cohort. The other thing about antibodies is that there are a lot of cross-reactivities with other viruses. So that diminishes their, I would say, their specificity. Next slide. So in short, the tests that we do are either molecular or are part of immunodiagnostics. The molecular one is the RT-PCR, and then there's a LAMP. I would just say a bit about it now. And then our immunodiagnostic, the one that we know is the antibody-based, but we can still, in that rapid test, do an antigen-based test. Next slide. As I go through detailing each of these tests, I just want to stop and talk a bit about the validity that is essentially expressed as sensitivity and specificity. I'll go very fast because I know these are basic info that we all have. Essentially, in the clinical medicine, sensitivity, we use it to exclude the diagnosis. So the higher the sensitivity, the best is the test in excluding the diagnosis. So if a test that has got high sensitivity, if it comes back negative, you can rest assured that the diagnosis is excluded. Whilst the specificity is actually good in including the diagnosis. But these are like looking at two different angles of the validity. And if you want to include these two aspects, then we have the notion that we've introduced of likelihood ratio, then that be positive or negative, and how strong a specific positive test is linked to the diagnosis, or how accurately a negative test can actually exclude the diagnosis. Next slide. So for your RT-PCR, it is interesting because this is a technique that has been used long before COVID came into place. And that's why it was very easy in the first week or second week after the pandemic was declared. We had actually, after the outbreak was declared, we actually managed to develop a test, an RT-PCR test for COVID, because the technology that exists already for a long time. The good thing about it is it helps you to make the diagnosis of a current disease. It doesn't take long, though in many countries when you do the test, they only give you the results the next day or after 2 days, after 3 days, and that it is because of logistical issues. They can't just cope with the amount of specimen that are coming to them. It's got good specificity of 100%, or positive is positive, and you can see the likelihood ratio, positive likelihood ratio of 64. That's quite high. Anything above 5 should be interesting for us. Unfortunately, it's costly. It has to be done in a lab, and a specific lab, just not any lab. Unfortunately, also it is dependent on the sample. So if you don't collect a good sample, then you're probably not going to have good result as well. Therefore, the sensitivity changes from the area where the sample was taken. So if it's a bronchoalveolar lavage, the sensitivity is 93%, which would not be common for us. Nobody would take all those patients to, or suspected cases, to bronchoalveolar lavage. Your sputum will give you 72%. Your nasal swabs will give you about 63%. I think that's a lot of authors talk about 60 to 70%, but this is incredibly bad for us, because you have about 30% of people that will give you a false negative result. So if you go to the stool, it's even worse. Next slide. So your loop-mediated isothermia amplification, the LAMP, uses the same principles as RT-PCR. It's just an issue of the temperatures that are used during the process that are different to the RT-PCR. It's said to be cheaper than RT-PCR and simpler and takes less time. However, it is still being investigated. There's no commercially made tests using this principle. Next slide. Yeah, so your antibody-based, what we call the rapid test, and there are two types. There is your lateral flow, which comes with cassettes. You put a drop of blood that will run laterally, and then will show you the results. And you've got your ELISA that is done in the laboratory. So your rapid test takes about 15 minutes and can be done by anybody. You don't need to be specially educated to do that. Your ELISA takes a bit longer, but it's still short time compared to your RT-PCR. The accuracy, I need to say that is not great. And there are a lot of studies that have been done. And you can see that there's a Cochrane review that was done by Dix and friends, and then was published on the 25th of June, had 38 studies included. What they found is that the methodology in most of those studies is problematic, and the sample is usually they use a small sample. So I know that CDC says that they are antibody-based, which is ELISA, has got those excellent sensitivity and specificity, but a lot of scientists have doubts about the accuracy of most of those tests. We expect that what they would show to us is that the person was in contact at some point with COVID. Next slide. And your antigen-based uses the same principle, but instead of looking for antibodies in somebody, they look for antigen, for fragment of viruses. And they would either be hopefully lateral flow or ELISA-based, and then be done in the laboratory. And a lot of people think that might be a bit more specific than the antibodies, because the antibodies have all issues with cross-reactivity and stuff. Unfortunately, it is still under development. We don't have so far commercially made tests. Then, next slide. So in summary, you have your RT-PCR and LAMP that are done in the lab. They look for your RNA, and you've got your lateral flow and ELISA that look for antibodies. Your ELISA in the lab and your lateral flow is actually a point of care. That's in summary. What we know in reality is that we only have two types of tests so far. It's RT-PCR and the antibody-based. Next slide. So what are the clinical implications of all that I've said? The advantages, disadvantages, and limitations of the different the different tests is that when it comes to making the diagnosis, so far what is proven to give you, what is proven to be reliable is the RT-PCR, not really the antibody-based. The antibody-based may be used to determine immunity in the population. Why we don't advocate to use it for diagnosis? The same Cochrane review that was done by Dix and friends actually showed clearly that only 30% of patients who present antibodies in the first week post symptom development, and you have about 70% in the second week. You have to wait the third week to actually get 90% of people developing antibodies. And that's bad, actually, you know. So you cannot say if you don't get the antibodies in the second week that you exclude them. And now the other thing is where is the place, can you go back a bit? Where is the place of all these tests when in terms of recovery? Can they help us to determine at which point the patient has recovered? Next slide. So again, I repeat myself, RT-PCR is the one for diagnosis. Just remembering that even your RT-PCR doesn't have a great sensitivity. So you need to be very careful as you interpreting. They might be false negative result. And that's where your clinical arguments and your X-rays and CT scan may come to help to rescue you in terms of deciding that despite the RT-PCR result, I would still consider this as COVID. Next slide. So I'll just show you an algorithm that was developed in one of African countries. I know it's in French, but it's not very difficult to understand. They actually tried to make an algorithm of that would use the antibody-based test to reach the diagnosis. They either included two antibody tests, and they said themselves, I didn't include that information, they said themselves, one of the tests, there is no publication about the validity of the test. And the second one has got a sensitivity of 69% for IgMs, which is a type of antibody that comes initially, and then 93% for your IgG that comes a bit later. So I've taken a portion of that and make it a bit bigger so that you can see. When you look at a patient that had symptoms, that's where it starts from the algorithm. Symptoms, yes, and then it separates those with symptoms between less than 1 week of symptoms and more than 1 week of symptoms. Now, if you look your far right, more than 1 week of symptoms, and then it says IgM negative and IgG negative, the algorithm considers these patients as not having COVID. Do you remember what I told you in the Cochrane that was published on 25th of June? It's clearly stated that even in your second week, which is more than 1 week, you can still not have antibodies in about 30% of. So that's incorrect. That's just to show you. But apart from that, you have all the issues of cross-reactivity. You don't know if all these antibodies are actually COVID-19, SARS-CoV-2, or other coronaviruses that we know are implicated in the common flu. And then there are issues of the quality of studies of assessment of the validity of the different tests. Next slide. Maybe of great importance, particularly for us in Africa, keeping in mind that logistically we have issues. We don't have the logistics to run all the numbers of tests that are requested every day. All that demand comes to us. And I think it's important that we stop and say, should we use the tests for recovery? Number one, I would say, the problem we have to use the RT-PCR for recovery is that RT-PCR detects viral fragments. And you saw in my previous slides that more than 8 weeks, more than 8 days, there are a lot of culture, a lot of samples that are, when they're taken to culture, they don't give anything. So meaning the virus is not viable anymore beyond that time. But also we need to know that there are people who can keep the viral fragments in the nasal secretions for more than 80 days after they have stopped having symptoms. So we need to be very careful to use RT-PCR to determine the end of the treatment. That's why nowadays we talk more about either using criteria that would be symptom-based or time-based. And if you want, you can continue using the test-based, but you need to know that there are caveats to that. So next slide. And if you go onto the website of the CDC, you see clearly that they give you criteria for symptom-based criteria, essentially for symptomatic patients. And they clearly say, if you have someone who was 72 hours without fever and without respiratory symptoms or just some mild respiratory symptoms, and not all, is 10 days post-initiation of symptoms, you can consider them as they have recovered and they can go back to work. When you look at it as time-based, which you essentially used mostly for asymptomatic patients, 10 days after they have done their PCR, which was positive, 10 days after, if they don't have symptoms, you consider them as recovered and you let them go. If you want to use the test-based, then you need no fever or no fever, no rest symptoms, and 2 PCR negative, you have to read negative, not positive, that would be separated by 24 hours. And that is a huge problem, that we are failing already in the beginning to do the test onto everybody. How can we then go and do 2 tests at the end to confirm that they're out of COVID-19? Next slide. If you go to the website of WHO, they have actually removed the test-based criteria. They use the symptom-based and the time-based. And again, they say for symptomatic patients, 3 days without fever or rest symptoms, and 10 days post-symptoms initiation. If it is an asymptomatic patient, then it's 10 days post the PCR positive. Next slide. South Africa would say for asymptomatic patient, 14 days post the PCR test. If it's symptomatic, mild cases, they will say 14 days post-symptom initiation. If it's moderate and severe cases, they will say 14 days post-use of oxygen. Countries like DRC also are trying to depart from there, but they're still struggling to remove the PCR. So instead of doing 2 tests, they say we do 1 test, and then if it's negative, we exclude you. We say you have recovered. Next slide. So in short, we have few tests, RT-PCR and antibody-based. Unfortunately, the RT-PCR, as you interpret it, remember, it's got poor sensitivity. There will be a lot of false negative. RT-PCR can be persistently positive, but because of the fragment of the virus that persists in the swab, but those are not viable viruses. Your antibodies, you have considerable amount beyond the second week. So we use a lot of clinical lab and imaging arguments when we making the diagnosis. That's important. But in brief, your diagnosis should be RT-PCR. If you want to do your herd immunity, your antibody-based. Your recovery, there's a lot of recommendation to use now your time-based criteria or your symptom-based criteria. And all of that is done because we looking at risk and benefits of using one or another. Thank you so much.
Thank you so much, Dr. Kabongo. The discussion for a couple of Q&As if there are any questions that people have.
And my question is addressed to Dr. Diulu. Of late, I've been seeing around people moving up and down with some certificate post treatment of COVID. How specific is that certificate, and then for how long would it be valid? Does it exclude that those patients, after being cured, they will not anymore any COVID? Thank you.
I don't know they're based on what when they give them the certificate, and I think that's my opinion. I think they're like overdoing stuff. I mean, please, so it means for every other disease we have to give certificate to people that they are cured, they can go around. I don't know why we would be doing that, but it's behind that question. There's an important thing that you said. Can we then say they cannot be cured? I don't think I can answer you like with precision and say this is what it is. One, because information is changing so fast with COVID. Two, we know also that there are some question marks on the ability of the antibodies, if at all someone develops the antibodies, their abilities to actually protect you. You have to remember that if you followed initially what I said, is there a set of antibodies that are produced to different parts of the virus, and unfortunately the bigger number of those will be directed towards the nucleocapsid, and these are not neutralizing antibodies. The few antibodies that are actually neutralizing are antibodies against your receptor binding domain. And unfortunately, there are only few that comes up according to the research that we know. But even if they are produced, we also know that patients, recovered people do not keep those antibodies forever. There are papers that talk about keeping antibodies for about 2 to 3 weeks, and then, to 3 months. Some say 6 months, but then you can see that these antibodies disappear after some time. So there is nothing like forever you will be protected. No. I don't know if I've answered what you wanted to know.
All right, so I think that concludes our webinar for today. Thank you guys again for joining us. And just as a reminder, we do have these webinars every Thursday, and we are looking to share widely this information and try to get as many people involved as possible in these webinars. So if you know anyone that might benefit from this information, please continue to share out our posts on Facebook, share the posters that go out through WhatsApp and through our MailChimp and through emails, and just let your colleagues and teammates know that these happen every Thursday from 2 to 3 p.m. Central African time. So we'll see you all next week. And again, please fill out that survey at the end of this event. Thank you all and have a great day.